Acquired brain injury is a leading cause of morbidity and mortality in the pediatric population. Despite advances in neurocritical care and improved mortality rates, survivors are often left with long-term neurologic and functional disabilities. In the acute phase, the injured brain is vulnerable to secondary injury due to changes in blood flow. At the bedside, we currently set age-based goals for blood pressure and cerebral perfusion pressure to maintain adequate blood flow during this acute injury phase. However, this does not take into account changes in what is known as cerebral autoregulation. Cerebral autoregulation is the intrinsic ability of blood vessels in the brain to maintain a constant blood flow with changes in brain perfusion. As you can see in this graph, in an individual without brain injury, over a wide range of blood pressures, the cerebral blood flow remains constant. This is achieved by the brain's intrinsic ability to constrict and dilate blood vessels with changes in blood pressure. When autoregulatory mechanisms are impaired after brain injury, changes in brain perfusion pressure will predispose vulnerable tissue to either ischemia or vasogenic edema. In more severe injuries, autoregulation is completely lost, and cerebral blood flow may be linearly related to blood pressure. Currently in clinical practice, the ability of the patient to maintain an adequate blood flow at a given perfusion pressure is assumed but not known. While this phenomena is well described, there is little data on children examining the incidence and temporal changes that occur after brain injury. Currently, there is no accepted gold standard or method for assessing the autoregulation after brain injury, and therefore it is not considered when clinical management decisions are being made. A significant hindrance to measuring autoregulation in the critically ill patient is the necessity of traditional methods to induce potentially harmful changes in blood pressure to determine the autoregulation response. However, alternative approaches have more recently been suggested by measuring the spontaneous and physiological waveform fluctuations that occur normally in humans in the systemic and brain vascular circulations. In this study, we will use two such novel methods. The first method, called transfer function analysis, assumes the brain to behave like a regulator with an input and output signal. The input signal being arterial blood pressure measured using an invasive arterial line, and the output signal being cerebral blood flow velocity measured using transcranial Doppler ultrasound. Due to the need to do transcranial Dopplers, this analysis can only be done intermittently during stable patient conditions. Secondly, this method does not allow us to assess the state of autoregulation at extremes of blood pressure. To overcome these limitations, we are using a second method to assess cerebral autoregulation called wavelet coherence analysis. Similar to the previous method, this method looks at arterial blood pressure as an input signal and cerebral tissue oxygenation measured using continuous near-infrared spectroscopy, or NIRS, as the output signal. We hypothesize that in patients with acute brain injury, transfer function analysis and wavelength coherence methods will detect significant changes in autoregulation over time. We also hypothesize that patients with greater number of abnormal autoregulation values will have a worse neurologic outcome measured by functional and neuropsychological outcomes. We will screen all patients admitted to the pediatric ICU at Children's Medical Center Dallas and obtain consent from patients who meet our inclusion criteria. Our data collection would involve serial transcranial Dopplers over the first 10 days. We will collect real-time data using NIRS monitoring during the same time. We would then use previously validated tools to assess neurologic functional outcomes over time. There will be several pitfalls that we may need to address as the study progresses. Although transcranial Doppler is a non-invasive, painless, and non-stimulating procedure, some of our patients may not be able to lay still for the procedure. We will discuss timing of the procedure with the clinical team, bedside nurses, and family to determine the best time during the day to optimize successful data collection while minimizing interruption to patient care. Due to severity of injury, some of our patients may not survive the first 10 days of hospitalization. We will attempt to account for this in all our data analysis. At the end of this study, we hope to address gaps in our current understanding of the incidence, temporal changes, and relevance to outcome of disturbances in autoregulation after acquired brain injury in children. Advancing our knowledge and use of methods to non-invasively measure autoregulation at the bedside in neurocritically ill children will lead to a better understanding of how the brain regulates blood flow after injury and potentially impact the care that is provided. We hope this data will lead to development of clinical methods to measure real-time autoregulation assessment to optimize blood flow and improve patient outcomes. Having such tools will further the ability to account for age and individual patient differences to tailor therapy based on individual pathophysiology. For this research project, we are collaborating with Dr. Purkayastha from Southern Methodist University and Dr. Tian from UT Arlington, who have extensive experience in the research methods we are using. Being at Children's Medical Center Dallas gives us the unique opportunity to study patients with the most severe neurologic injuries, and my goal is to enhance our ability to care for these patients and allow them to reach the most meaningful outcomes. Thank you for giving me the opportunity to share my work with you.